temporomandibular disorder. We're mainly looking at physiotherapy management of these disorders. Okay, so that's fine. Yeah. So I was just going to mention any questions that you have. I'd rather you write them down, and we'll try to fit them in at the end because we've got a lot to get through in quite a short period of time. So I've just introduced myself. My name is Philip Bateman. I'm a physiotherapist. I did my initial degree here, and I also did my master's here a few years ago. I'm a member of the Association of Chartered Physiotherapists in Temporomandibular Disorder, and that was that group came together in 2009, and I started with the start of the group at that time. I'm an extended scope physiotherapist, and I work at Sheffield Teaching Hospitals. I work in 3 areas of the hospital. I work in the outpatient department at the Royal Hallamshire Hospital. Near enough all my patients are facial pain patients. I do see some spines, but most of the patients I see are facial pain. And these patients come from the Charles Clifford Dental Hospital, where I also work as an ESP in one of the TMD clinics over there with one of the consultants. And finally, I work 1 day a week with the neurosurgeons in a spinal clinic at the Northern General Hospital. So what I want to do first of all is give you a simple definition of temporomandibular disorder. So it's a term used for a number of clinical problems that involve the jaw muscles and the jaw joints, and these are musculoskeletal problems. So really, physiotherapists should be involved with these kind of conditions, particularly persistent TMD. So, I don't know if anyone actually treats TMD patients, but what kind of symptoms or signs might you expect if someone came into your clinic or your department with this?
Painful clicking.
Pain, clicking, yeah. Painful clicking, yeah.
Difficulty opening your mouth.
Yeah, so limited movement, yeah, definitely, yeah. That's probably the main ones, really. Okay, so yeah, pain and tenderness over the jaw joint and jaw muscles. Pain is usually aggravated with jaw function, so things like chewing, yawning, limited range of movement, as mentioned. It's not always, but often. Asymmetrical movement, so people might get deviations. Joint sound, so clicking, also crepitus, some patients report crepitus. So those are the main symptoms. In terms of the size of the problem, prevalence is, this is a fairly conservative statistic, 1 in 4 is all the stats out there. So it's fairly common, and those seeking treatment, you're looking at about 5% of the population. So, reassuringly for patients, symptoms are common in the general population. However, most patients, or most people, it only lasts for a few days to a few weeks. Those that are seeking treatment, persistent TMD, are those that 1 in 20, are usually having problems with quality of life and problems with coping with the problem. So what we wanted to cover in this module is TMD anatomy, classification, assessment and treatment. So it's quite a lot really. Anatomy and classification, I think you've done some, hopefully you've done some reading, you'll get your references. So there was some reading set with task 1 on functional anatomy and classification. In terms of assessment and treatment, there was some other articles and literature that you were given on assessment and treatment. And there was some optional reading that you might want to have a look at. Today we're going to look at some theory, and we're going to actually look at some practical regarding just the assessment and treatment. So starting with assessment. For persistent TMD, the common patient experience, unfortunately, that I see on a daily basis is delayed and conflicting diagnoses, multiple failed management, lost hope, and ongoing suffering. And I think to some extent these kind of things that patients experience is actually leads to a challenge to treat these patients in addition to some other factors we'll look at. So we're going back to the simple definition, but although these conditions involve the musculoskeletal structures, it's not just about musculoskeletal structures. Persistent TMD will usually be associated with a complex combination of driving factors that maintain an ongoing cycle of pain. And some of these factors are biomedical, so we're looking at pathoanatomical, neurophysiological, physical and comorbidities and genetic factors. And some of them are going to be psychosocial, and here we're looking at cognitive, the way the patient thinks about their problem, psychological, emotional, and social and lifestyle factors. So, therefore, management of persistent TMD needs a biopsychosocial assessment to identify both the biomedical and psychological and social problems, drivers or contributing factors for the patient's disorder. And it needs tailored patient-centered interventions to target those particular driving factors for that patient. So long-term successful management is going to depend on identifying those primary driving factors that are causing overloading and to the patient's actual masticatory system. Success is going to be proportionate to the thoroughness of your assessment, and it requires you to understand most of the potential driving factors for that patient and to minimise those driving factors. So to help with this, you've all got a copy of a clinical reasoning tool that I put together. Now, I just stole information from other authors really to put this reasoning tool. And the main two authors that I took the information from was Peter O'Sullivan, who's a spinal kind of specialist physiotherapist, and Anton Luija, who's in Holland, and he's a specialist in TMD physiotherapist. So the clinical reasoning tool, the aim of it really, I use this tool in mentoring at Sheffield Teaching Hospitals for complex patients really, to try and think of a logical pathway of thinking for the staff. And it's to help determine really the main driving factors for different patients, and then evaluate maybe their prognosis. And the prognosis isn't just for your information; it's for the patient's information as well. So, an explanation to the patients about why their condition is going to be quite hard to turn around is important as well. So, to try to make this session a bit more clinical, we're going to use a case study to go through this clinical reasoning process. We're going to use Mary, and I think you should all have a copy of her clinical presentation. When Mary comes into the department at the Hallamshire, she's going to get some outcome measures, and the main aim of the outcome measures is to measure outcome, to give us some evidence of intervention, and it's also used as an assessment tool really, particularly the functional one, to identify patient problems. So this is the outcome that she'll, the first outcome measure she'll fill in. And what she'll do there's 17 different functional activities there, and she'll she'll tick a box from no difficulty to the most to very difficult or unable to do without help, and it scores from 0 to 4. And then we'll add up the score, and she'll get a before treatment score, and then she'll get another measure after you've all used these measures, I'm sure. And hopefully when Mary leaves the department after all the treatment, she'll her score will reduce by 10 or more units to define a clinical change. The next thing she'll fill in is a visual analog scale, and I'm sure you've seen this before. This is a line, a 100 millimetre line, and Mary's going to score from no pain to the most pain she can imagine. And she's going to score up before and then after, and hopefully her score will reduce by 15 millimetres or more at the end of treatment. And then finally, when you do your examination, you'll be measuring mouth opening before and after. And if she has got limited range of movement, which Mary didn't particularly, hopefully that will increase by 6 millimetres. So the other thing that we use at Sheffield Teaching Hospitals is a prompt form. And this involves 4 pages, and you should have a copy. It involves presenting symptoms on the first page, clinical history, physical examination, impression, and path. And you should have an electronic copy sent out to you. Now, it's not a rigid tool, stress to our physios. It's just really a guide for assessment, and we want consistency. So it's a busy department. Physios are moving from, are rotating. Patients move from one physio to another physio. So we need some consistency for this for the assessment. So going back to Mary, she's got right-sided facial pain and tightness, and it's mainly over the ear and the right side of the mandible. She's got constant pain, scoring between 4 and 8 out of 10. She has this click, described as not painful. The pain is aggravated with activities like chewing, talking and yawning, but it's also related to stress. And she gets pain most mornings, severe pain most mornings on waking, which lasts around about half an hour. She admits to daytime clenching and nail biting, and these triggers for this that actually increase this are when she's concentrating on the computer or driving, but also when she's stressed. So she's had a click for quite a long time, and sometimes it's painful, but it's not currently painful. She's had a gradual onset of pain over the last 3 years, and now it's become persistent. Onset coincided with a mother's illness. Unfortunately, she died with a diagnosis of cancer. Initially, a GP diagnosed ear infection, but antibiotics didn't work, so she went on to ENT. And then we do get quite a lot of referrals from ENT. Eventually, it came to the dental hospital, Charles Clifford Dental Hospital, and TMD was diagnosed. And she describes the symptoms as generally slowly worsening. She reported general health as good, moderate levels of stress in her life, and she drinks quite a lot of caffeine. So, in terms of a social history, this is kind of part of the source of her life stress. She's a busy office manager, and she's got 2 unruly teenage sons. On further questioning about her pain, she's quite anxious about the cause of her pain and her clicking. And partly this appears really that she's had the pain for 3 years, it's worsening. Her mother's recently died of a major illness, and she had a conflicting diagnosis initially. So you can see why she wasn't really on board yet. So looking at the physical examination, the aim of the physical examination really, we've just got from the presenting symptoms and history, we've probably got an impression of what's going on with Mary, hopefully. And the examination, all it is to actually support or confirm your impression or reject your impression, really. And it's a fairly short examination, which you'll see. Really, the examination is going to involve observation, looking at movement. This is the musculoskeletal side anyway, looking at movement and looking at palpation. And there's a really good website that you might want to have a look at, this rdctmdinternational.org, and it gives you full instruction on, a very detailed instruction on the examination, and also gives you lots of screening and outcome measure tools. So Mary's teeth were in contact at rest, And when she spoke to me, she was kind of talking through closed teeth. So there seemed to be a lot of activity around the jaw. Intraoral inspection, we identified some cheek ridging and tongue scalloping, which kind of points towards evidence of overactivity of the jaw, so that people tend to bite on the tongue and the cheek, so what we call parafunction. All parafunction is activity beyond normal function, so we all talk, eat, and everything, so, but biting nails and chewing chewing are not things you have to do, really. Forward head posture, which might be important because she's an office worker and she sits for long periods. Looking at the pattern of movement, when she opened, she had a right-sided deviation that corrected itself, which we put on the movement diagram. This movement diagram, P stands for protrusion, R and L are right and left lateral excursion, and O is opening. And they're supposed to measure, the P is supposed to be 10 millimetres, right and left is supposed to be 10 millimetres, and it's supposed to be 40 millimetres opening, and that's kind of the usual ratio of movement about as a guide. So we put the right deviation on there. Now we're going to feel and we can listen to noises. I tend to mainly just feel for noises, but some of the physios tend to keep their old stethoscopes out that I haven't used for years and use that. So we can mark the click on, and the click was associated with the direction of the deviation. Then we measure range. So we've measured the opening and lateral excursion. Didn't measure protrusion. And the movements are limited, but equal on both sides, so right and left was equal. And she did have some limitation, but on overpressure, it increased, the opening increased. So next we moved on to palpation, and these are pain provocation tests. So we palpated the joint itself, and she reported tenderness on palpation, no tenderness on palpation of the joint, or joints, and then we palpated all the muscles, and masseter, she did report pain, and she also reported some referral into her usual pattern into her ear. So when I come across, and hopefully when you come across these kind of things with patients, I instantly use that as something to support your benign diagnosis. So I'd ask Mary to have a feel of that herself, make sure she realised it was the actual structure of the spine was a muscle, and when she feels it and it's very sore, and she's very surprised, and she's also quite surprised it's a muscle. It's just reinforcing diagnosis directly, and this has a big influence, I think, this type of... so you're using your assessment as part of your treatment and reassurance, and I think that's very important. The information is not just for you that you're getting from an assessment, it's mainly for the patients, I think. So she was very tender over the masseter. So what we've done, hopefully with the examination, is supported our classification or diagnosis. So what we're going to do now is we're going to use the Mary's case study, and we're going to run through the clinical reasoning tools to try to find what her primary drivers are for her problem, and then have some idea maybe about prognosis. So the first thing, if you look at your clinical reasoning tool at the top, we're going to consider all the sources. So there's many conditions that will present with facial pain, and we need to be aware of all the pathoanatomical sources. And in the literature, this splits, it's a little bit like spinal pain, probably other musculoskeletal problems. It splits into non-TMD, less common TMD, which includes serious pathologies, and more common TMD, and these are musculoskeletal TMDs. So we're going to define those a little bit. So starting with non-TMD, what we're looking at here are signs and symptoms not from the muscles and the joints, the joints themselves. So this might include referred pain, it could include inflammation, infection, and the most common source of pain, always think when someone comes to you in pain, think teeth. most common cause for facial pain is toothache, so keep that in mind. Neurovascular syndromes such as trigeminal neuralgia and temporal arteritis, and then this kind of label of medically unexplained physical complaints, and some of these patients get diagnosed with atypical facial pain, which doesn't really have that much meaning really, so we don't really know, and that's what that is. For Mary, do we think she's got any of these? So I scrubbed that, great, got that out of the way. Less common TMD we're on next. So the less common TMD, or more specific type of disease we're looking at is things like neoplasm, cancer, local fracture, maybe a fracture of the condyle, infection of the joint itself, systemic disease such as rheumatoid arthritis involving the joint, growth disturbances, and growth disturbances are common more in teenagers. Fortunately, in the literature, we've got some indicators for serious pathology, and these have come from the spinal literature, but they're general indicators. And the index of suspicion for these indicators is raised as the number of flags increases. So what do we think about Mary? Has she got any of these? So Mary's got the constant progressive itch. She's got one indicator. She's got persistent pain, and which is fairly common with the musculoskeletal problem. So we're not getting too anxious about this. If she's older than 51, and she's reporting severe night pain, and she had a history of thyroid cancer or breast cancer, then we would start thinking, okay, further investigation. We need straight away we'll be thinking that type of thing. There's also more specific indicators for the head, neck and shoulder area. And if patients are reporting any of these problems and they've got facial pain, my advice would be to direct them to a general dental practitioner or general medical practitioner for further assessment. We've got, Mary's got this constant severe, occasionally severe progressive pain. As physios, we can't be really expected to be very good at assessing intraorally. So with skin lesions and stuff, you might see these things, but anyone that you see that's got facial pain, my advice would be make sure they're being screened by their dentist. So next, so we need to, what we're saying here, we need to consider other conditions, other sources for the patient's pain that may need further investigation for exclusion and diagnosis. So we're finally on to more common TMD, which for persistent pain, this is the most common cause for persistent pain, facial pain. So these are conditions that involve muscles in the joints, and a classification, and I think you've got a copy of the latest classification, this Schiffman article. It's been developed, this classification, and signs and symptoms can be used as a guide for treatment. So it's very simply, in a simple ways, the problems are divided into muscle, joint and headache really. And I think for most patients that I see with headache, it's probably muscle anyway, it's probably temporalis that's involved. The patients I see, it's really common to have a mixed presentation because they've had problems for such a long time. But what I'm looking for is a dominant problem, so trying to split it in whether it's more muscular or joint dominant. So Mary, what do we think? Muscular. So we've got muscle. Did you say muscle? Yeah, definitely muscle. Anything else? Yeah, so she's got some joint noises and shit, but a joint's not painful currently, but it has been in the past. So I thought it was a mixed classification, but the primary source of the problem at the moment is right, it's muscle, but she has got this right-sided articular disc displacement with reduction. Now, hopefully you come across that term, and this is really the pre-reading, it's probably important really to look at the classifications. So the click is a disc displacement. We'll look at this a little bit more because when I go through the treatment, I'm going to explain the condition to you as I would to Mary. Okay, so hopefully. So the classification that we've just looked at is just really looking at pathoanatomical factors. However, as with other persistent musculoskeletal problems, we know that, such as persistent back pain, we know that pathoanatomical factors aren't the only driving factors. And persistent TMD usually is associated with a combination of factors, biomedical and psychosocial. And what we need to do is assess for all the factors. So we've only looked really at pathoanatomical with that top section, and we've got to consider some other things. So next we're going to look at pathophysiological, and here we're looking at the stage, progression, behaviour, mechanism of disorder. And really what we're looking at is how sensitive is Mary's pain system. So what do we think in terms of stage? So, myself. And progression? Yeah, so it's deteriorated. Behaviour and mechanism kind of mirror each other really. P and F is peripheral nervous system versus central nervous system, the bottom one. I kind of sat on the fence here, and the reason why is that she's got pain varies with jaw function, and also it's worse in the morning after she's probably bruxing, which have you come across the word bruxing? It's all it is clenching and grinding at night. However, so that's the kind of the mechanical peripheral side of things, but she's also got constant pain, so it's always there, and it varies with stress, so there might be some central sensitization there. Now, literature again gives us some features of centrally mediated pain, so we talk about persistent pain, pain that's constant, disproportionate response to mechanism, and no clear anatomical origin. So that means that, like, we'll get some patients that have got a whole quadrant of pain, so that obviously they're sensitized. No clear anatomical origin. Hyperalgesia, allodynia. Have you come across those terms before? So some patients, you'll just touch the face, so you have to get when you're assessing, but and they'll report pain just on touch, and associated with psychosocial factors. So if people are presenting with this, you might start to think about other interventions. You must have come across amitriptyline, yeah. So amitriptyline, one of the tricyclic antidepressants, probably one of the first ones people put patients on. It's probably the oldest as well. No side effects. So with Mary, what we've got is we've got chronic, persistent, and it's associated with stress. So there's some of that central sensitization. Next, we're looking at the physical. So this is where we want lots of issues around physical, because we're physiotherapists. So with physical, we're looking at anything that might physically stress, strain, or load the jaw or muscles, jaw joints or muscles. And this could be macro trauma, so a direct blow or something indirect, like a road traffic accident, maybe a removal of a tooth, or maybe any surgery to the head, neck and face. But that's not Mary, so we're probably looking at more micro trauma with Mary. The other thing that we have to put in terms of physical factors, we have to put context with Mary. This coincided with a stressful life event where it's likely that her coping capacity was reduced and driving factors were increased. And for those that probably treat persistent pain, this is a fairly common clinical history really for back pain or whatever. There's sometimes often an emotional event occurring in people's lives. So posture. Do we think there were some postural issues? Yeah, so we're talking about really, when we're talking about posture, we're talking about mainly neck posture and jaw posture. And she had the common ones, which was a forward head posture and teeth were in contact. Parafunction. Yeah. So she was boxing probably, or she had some at night and in the day, nail biting, and another thing that she was probably doing is like talking excessively, you know, like work and then at home. So she's doing a lot of talking. Movement patterns. The only movement pattern really related to her mechanical dysfunction of her jaw, which is very common, but it was that deviation really. In terms of muscle activity, I think that there was lots, and probably related to guarding and also related to stress related to tension. Now the thing about overactivity of muscles, this can increase activity of muscles, will obviously load the muscles and can produce muscle pain. The other thing that it can do is overload joints and increase joint pain. So if you think about just the wrist, and you'll put your hand up into the air, that's it, okay? And if you just do your wrist back and forwards, and it feels lovely and smooth, most things, you know. You clench your fist, and now move your wrist backwards and forwards. If it's as old as mine, you probably feel some creaking and clicking, and it might be a lot stiffer. Yeah, maybe. So thinking about that can happen with all joints, particularly around the back. We're looking at also around the jaw. So masseter crosses the joint very closely, so does temporalis. So if you imagine that if they're constantly active, and it's amazing. You treat these patients. It's amazing what happens to the actual clip or crepitus when you just massage the soft tissue. And I think what's happening there is just that you're just getting some release of that compressive element. So I think this is something that clinically I think is quite important. So yeah, so we give her a mark, and luckily she's got loads of things going on there. It always worries me when I score nothing on here, and then I'm thinking, well, I'm a physio, you know, like, I'm not a psychologist. Okay, so this might indicate that she might, a splint might be useful. She can't concentrate on her jaw position at night time, she's asleep, so the best thing at night would be a splint. So, genetic and comorbidities. So here we think about things like health and comorbidity. So rheumatoid arthritis could affect the joint, fibromyalgia could affect the muscles. Medication, has anyone come across sertraline? It's an antidepressant. So that's quite common, something that's quite common in the dental hospital we've come across. And it's been associated with bruxing at night. So I suppose you've got to look at the whole picture, but if the patient's coming in and said, you know, you've asked about medication, when did you start it? Oh, it's about similar time when my bruxing starts. So it's very closely connected, and you've got to think that might be one of the major contributing factors. And that's a communication with the GP or whoever prescribed that medication. And it might not be that come off the medication if it's important. Then obviously the mental health is important, probably far more important than this. But it might be that they might swap and change the medication or reduce it or whatever. Okay, so dental. I meant to dental. Hypodontia is just a reduced number of teeth. And if someone's got hypodontia at the back and don't have dentures, where do they chew? They'll chew at the front. Now, if you chew at the front of the jaw, your actual condyle has to come out of its nice stable fossa further, and then you're using the jaw in a place where it's for long periods and using quite heavy activity in a place where it's not as stable. So that could potentially give joint problems. If it's one-sided, then you're going to chew on the other side and you're just going to overload one side compared to the other, so you're going to get asymmetrical loading. If someone's wearing dentures and they're not fitting properly, what they're going to do? So if my dentures, I'm fearing that my dentures are going to fall out. Yeah, so you're going to bring your teeth together, aren't you, to keep your dentures in. So that's going to load the system, probably for long periods. It might be low level, but it's long periods. We didn't think Mary had any of these problems anyway. Going on to the psychosocial factors, it's important really that we stress the patients in some way that these aren't the cause of their problem, but they will contribute. With most of the patients, nearly all the patients, there'll be some contribution. So a little bit more about psychosocial factors. For persistent orofacial pain, the research tells us that psychosocial factors are more strongly associated with a patient's pain intensity, disability and prognosis and the biomedical findings. Therefore, patients with persistent disorders are unlikely to improve if you just apply biomedical treatment. So in addition to this, we've got to think about assessing and treating other drivers, psychosocial drivers. So looking at her cognitive and psychological factors. So with cognitive, we'll talk about the way that Mary's thinking about her disorder might contribute, and also talk about her emotions and psychological. So some of the, from the assessment we've got she's got some confliction in a diagnosis. She's anxious about the cause. She's recently experienced the death of a mother from a serious illness, and onset coincided with this. So we're going to have some element of threat, emotion, and which is likely to increase some attention and sensitization, central sensitization. Looking at social and lifestyle factors, so social lifestyle factors, she's had moderate levels of stress related to a job and family, and she's also caffeine. Caffeine is a stimulant, so particularly if patients are drinking it before they go to bed, it's likely that they're going to be bruxing. It's a muscle stimulant, increase tension in the muscles. And if you're going to get any tension anyway, it's going to be around the neck and the muscles, because we express ourselves through this area, in terms of body language. So when everyone's stressed, they'll probably become more tense around this. But if you've got facial pain, it's going to influence it a little bit more. So with every patient, with persistent problems, we need to be asking, are signs and symptoms associated with a dominant psychological disorder? So this might include a major depression, anxiety disorder, or post-traumatic stress disorder, because it's very unlikely that you're going to actually get anywhere with these patients unless they have psychological intervention. So it's probably important, and we're not as good as we'll probably think we are at measuring this, so it's probably nice to have something like a tool that you can use for this. And we use a very short questionnaire that's supposed to be effective. It's only got 4 questions. And the top 2 questions, if the patient scores over a certain, gets a high score of 3, or 3 or more, it's likely that they've got an underlying anxiety disorder. And for the second 2 questions, you're looking at scoring 3 over 3, a depressive disorder. So it's quite useful. With Mary, she scored low on this, and I'd expect that. She has got psychosocial issues, but they're not dominant. It's quite natural if you've got pain for such a long time to have some of those issues. So, looking at the assessment form now to what we've filled in, the kind of things I'd be thinking of poorer prognosis is that she's got some neurophysiological issues like possible central sensitization, some level of central sensitization, and it's deteriorating, so we've got to turn something around that's getting worse. And then she's got some psychosocial issues there as well. So those are kind of pointing to a poorer prognosis. The main thing from a physiotherapist, from my side of things, is that I do like when patients have lots of physical issues, because I think there's something somewhere there you can just get in there. So that's a positive to me. So this is just giving you an estimate. After you've been through this and you've seen lots of patients very similar, it's probably giving you some idea about prognosis. And if someone's got lots of driving factors that you're not going to be able to affect, then obviously it's going to be a poorer prognosis. So I scored her a good moderate. I don't think she would have got better without treatment at this stage. And I think even with treatment, it's likely that it might be quite difficult to turn around. But the most important person to know this is Mary. You know, like, so it's going to be, you know, difficult to turn around. So we've done this biopsychosocial assessment. We've got some idea about her main drivers, and we've hopefully got some idea about prognosis. We've excluded the most common problem we think we have is dental pathology for acute facial pain. We're thinking about her problem is common, the most common persistent form of orofacial pain, but we don't think it's a serious specific medical condition that needs further investigation. We don't think she's got dominant psychosocial issues that need further psychological input. So what we're left with is this common musculoskeletal disorder, which we're going to tailor our intervention according to her drivers. So according to a pathanatomical diagnosis and all the drivers. So what we've done a thorough assessment. We've got an idea of what her main drivers are, and next what we're going to look at after we've done some practical is going to look at how we're going to target those main drivers. Okay, so we're going to do some practical and assessment now. So what I think we'll do is we'll get a bed, and we'll hopefully get a volunteer, and I'll show you some of the assessment techniques. And what I'm going to be looking at, you've got an assessment page on your handout, the assessment handout. Well, because we haven't got that much time today, I'm going to try to give you, or present to you, that the most important, in terms of the literature and myself, the most important parts of the assessment are musculoskeletal problems to identify which one are problem. Okay, so
yeah, drag a bed out and yeah.
You might want to so we've got some equipment here, so who's daring?
And doesn't mind being videoed.
I don't mind.
You're not? Correct. We're going to split it up into two, so I'll do some of the stuff, and then you can go and have a practice, and I'll be around, floating around to ask any questions. So have a lie down in the back. So before any assessment, particularly around the head area and the mouth, I'll be explaining exactly what I'm going to do before I do it, and I'll also ask the patient, because they might not be able to talk sometimes, I'll be asking the patient if they can just put their hand up and I'll stop what I'm doing and we can discuss. Okay, so the first thing I'm going to do is something very simple. I'm just going to have a look inside his mouth and see if he's got any ridging or any tongue scarping. Okay, so let's see if he's
Did he brush his teeth?
I'll move around here.
I've had a breakfast.
Okay, I'll pick some of And he's got a little bit of tongue scalloping, but it is very minimal, really, so well done. Okay, so the next thing I'm going to look at is we're going to, and you can have a look at each other, we've got some torches here, is, let me just get some more. So the next thing we're going to look at is just related to movements, really. So I'm going to have a look at his opening first. So I just want to have a look at. Now you can do this. You get various people doing different ways with like everything really. But what I'm going to use is I'm going to use his nose as my reference point, and I'm going to look what happens to his chin when he opens his mouth. As wide as he feels comfortable, and then close and open.
Right. Smile for the camera.
Close. One more. So there's a little bit of a wiggle. Okay. Do you have a click?
No.
No, so a little bit of a wiggle towards the end, but you know we'll get variations. Next thing I'm going to do is I'm going to have a feel of his joints. Now, if you put your fingers in front of your ears, just in front of the tragus, which is that fluffy bit there, and wiggle your jaw from side to side, you should feel your condyles moving. If you open your mouth wide, the condyles initially won't move very far, but when you open it wider, they'll travel forwards. Yeah? So that's all I'm going to feel, is I'm going to have a feel of the condyles. So if you just open, and then close, and then open, and close, and there's the condyles there, open. So I can feel them moving back and forth, and smooth as anything. Great. So we know that he's got a nice smooth moving joints. Okay. So the next thing we're looking at, so we're going to measure range of movement. So I'm not going to, now different people do different things. If I was doing research, and it's important to get measures right, if I was doing research I'd be using one ruler, put it on his tooth. But what I'm going to do is I'm going to get him to open his mouth now, and what I'm going to do is put the ruler next to, and I can see he's got about 46 millimetres there, and you'd expect around about 40 as a general rule. He's quite a tall chap, big chap, so that's very normal, 46 millimetres. So that's my first measure. The next measure, what I usually do is eyeball this measure, but use his teeth. So if you growl for me, but don't make the noise, okay? You can see that he's got the two middle teeth on bottom and top. He's got a gap between. Now you use those as a reference point. Now when he takes his jaw over to one side, you see it probably moves around about. See that it's moved more than about one. Take it over to the other side, and one. So you can use the number of teeth and just come over to this side again. So you'd expect about 2 teeth moving. So using the top one as the reference point, and then the bottom of the teeth should move across about 2. If you want to measure it, what you're going to need is I'm going to use a ruler. I'm going to use a straight and then just give it a quick wash. So I usually wash the ruler if I'm going to measure foot contact. Usually. You can have a go with this. So I'm going to put it on 4. On 4, just open your mouth, and then close, and then just open it a little bit, just to close a little bit more. So I'm going to attach the ruler to his teeth, okay? And then if you move it to one side, what you're going to use is that middle bit again. So he hasn't got the full centimetre there, and then move to the other side. And that side he's got a centimetre. So you can see there's a slight difference from one side to the other, and that might be the reason why he's got a bit of a wiggle when he opens it. Okay, so
in the literature,
yeah.
they talked about overbite.
Yes, measuring overbite. Again, the literature, I occasionally, if someone's got what we call an overjet, so overbite is, the actual correct term is where the teeth come down further. Overjet is when you come forwards. Okay. So if someone has an occlusion, and that's a type 2 occlusion, then I might be tempted to measure it. And the only reason I'm going to measure it then is because I want to know where they're holding the jaw in a normal posture, because you'll get patients that have got a type 2 occlusion, and for psychological reasons or aesthetic reasons, they will generally hold the teeth to give the appearance of a flatter face. And the same with a type 3 occlusion, which is where the jaw comes forward. They'll pull the jaw back into position. And this could be a driving factor for the pain. You know. So I would on that, but I'm not that interested with this chap. Okay. So next, what are we doing next? So we've done that. Now, if he had some limitation, just open it halfway this time. Okay. So what I'm going to do is I'm going to put my finger on my index finger on the bottom, and my thumb on the top, and use a scissor kind of action. And what I'm going to tell the patient is I'm only going to gently assist opening a little bit further. So we want to just have a look where his actual tooth is there, and then all we're going to do is just see if it opens a little bit wider. What does that tell us then? What do you think? Say it opened an extra 5 millimetres. Do we think joint or muscle? Yeah, soft tissue. It's going to be. If he's got a locked jaw, I'm going to do nothing. If he's got a very active mastoid, I still might not do anything. So it's not going to give you a definite. But once you relax that, you'd expect it to open a bit
So
more.
did you just pull them apart? That's what you did?
Yeah, and if patients come and they're fear phobic, totally doing anything like that, and you get a kind of impression of that, because I'd explain what I was going to do, and they'll just say, no, I don't want you to do that. Get them to do it. Just ask them to just show them the technique, and then you just measure. I don't usually measure eyeball again. It's very obvious when someone opens that, and you'd expect around about 5 millimetres to be relevant with that. So we've done that. So I think that's what we'll leave it at the moment. So the pictures are on there to remind you, and just let me know if there's any problems. So we're just looking inside the mouth for any parafunction. We're looking at opening for pattern and have a feel for any clicking. Now, you get various different ways of palpating. I think probably the best way to palpate the joint is usually the posterior. With some of the reading, they might tell you that. So most of the neurovascular structures in the joint are at the back, and if you get inflammation in the joint, that's where it's mostly going to be painful. So if you open your mouth as wide as you feel comfortable, I can feel right behind, because it's got good range of movement. The condyles come right forwards, and if I press into there and she reports pain, then she's probably got some inflammation in the joint at the back. So you're going to compare one side to the other, and really you wanted to know whether it's her pain in the same region where she reports pain. When patients are saying, if you ask them, where's your pain, and they go, there, you're starting to think, obviously, joint. If they're going anywhere down here, you start to think, well, maybe it's more muscular, myogenic type of pain. Possibly. Okay, but the joint structures can refer, so we've just got to be a little bit careful with that. So that's one way of palpating. Now, if she had limited range of movement, how else do you think we could palpate her joint?
Inside.
Yeah, so from the ear. So if you turn your head, and if I just place my finger not too deep into the ear, and if you just open now, I can feel, you can see how the joint just moves forward. Yeah, you know, like it. And I can feel the joint move forward. So if you put your fingers in your ears, if you dare, but don't go too deep, and then put your fingers to the front of the ear hole, and then wiggle your jaw from side to side, you'll feel the condyles hitting your fingers. You should do. Yeah, or you feel clicking. That's the best way of feeling a click. Yeah. If you want a patient to feel a click, you'll feel some crepitus. So that's your first thing, is palpation. So have a go with that. Next thing that we're going to palpate is the temporalis muscle. Okay, so and basically the temporalis muscle starts here, and if you want to actually feel where the margins are, just ask the patient to clench it, and I can feel here, and you'll be able to feel as the clenching stop clenching where it actually becomes prominent, comes down. So that's, but basically what you're going to try to do is palpate the front, go around the back, and you're asking where the tendon is. Now, usually when patients have tenderness in here, it's where the muscle belly is. If you look at the skull and see the indentation here, that's the thickest part of the muscle. The muscle belly will be here, and I'll show you. Muscle belly be around here. So if you clench, I can feel it, and then I can just feel boop, boop. So palpating there is usually where the patients tend to report most of the discomfort if they are getting discomfort, or cramping in this area. Next, going to the masseter. And I'm going to be systematic. The masseter attaches into the zygomatic arch here, so that's the top. And if you put your fingers just under the zygomatic and you clench, you see how my fingers move out? That's the top of the masseter. Just clench one more. Yeah. If I want to feel the front of it, just clench. See it come? Yeah. That's masseter I'm feeling there. And at the base, it's attaching basically to the mandible here. And if you want to find the actual muscle belly, there's the angle. Just coming up and forwards, and if you clench, boom. And what does anyone do acupuncture? What's that? Stomach. 6, is it? Maybe. Good acupuncture point that. Yeah. So and then it comes into the back. Also, you be a little bit careful because masseter also winds around a little bit around the back. So some people will have real tenderness around the back here as well. And there's another muscle, big muscle around the back. What's this? Yeah. And there's another muscle that attaches from here into the hyoid and back here, and attaches into just in front of the sternum. Does anyone know that? Has anyone done the reading? An opening muscle of the jaw. Begins with D. Digastric? Yeah. Okay, quite a complicated muscle. But we don't worry about it. It's very rarely painful, but sometimes it is. Particularly if people have had surgery on the neck, like for cancer and stuff. Okay, so that's that. Now, the best way of palpating masseter is if you open and then close. So what I'm going to do now is I want to palpate masseter again. You can go along the top just as I did, but if in terms of where the masseter usually is most painful, if you ask the patient just to open the mouth tiny amount, that's it, so it's relaxed. And what I'm going to do is I'm going to go back to the rami of the mandible and feel that right back there. And I'm going to go up to the top of the rami and I'll hit the zygomatic arch. I'm in a corner now. And what I'm going to do is bring my fingers back to the very back of the muscle, near enough to the joint, just below, right at the earlobe. So can you see my fingers at the earlobe? And now I'm in a corner. I'll show you this on the skeleton. And then I'm going to just squeeze. And it's a bit sore.
That's not comfortable.
Okay, yeah. So it's not comfortable on most people. You want to check from one side to the other. But this is, you're getting quite close to the joint. So if anyone's going to have pain, it's often around that joint area where the muscle might have gone into a little more guarding around it. So people will have different portions of the muscle that will be painful. So again, be quite systematic. Some people will have it very at the front of the muscle. And you're looking for, maybe looking for cervical trigger points. Well, they exist, whatever they are. But we'll talk about those in a bit. Okay, so have a go with palpating the jaw. So we're on to treatment, so it should be 20 past-ish. Okay, so we've done all this, and now, so at this point, you don't forget all about your assessment. Your assessment should relate directly, or your treatment should relate directly with your assessment findings. So there's lots of interventions for TMD. The main three, this isn't my slide, this is a slide that I got from the dental consultant, the dental consultant in Sheffield. And her idea, the main treatment techniques really is education, number one. The patient knows what's going on, hopefully reassured. Physiotherapy and splint therapy are the top. She'll also they'll bring in like medication. The kind of main medications are the tricyclics to get some relaxation and also reduce some of maybe sensitization of the nervous system.
Sorry, with this splint therapy, do you mean?
Yeah, so night splints. Yeah, so they'll be given a splint to wear at night. Yeah. And all it does is it's just putting the jaw into an occlusal position that's supposed to be neutral-ish.
And do you have to get those through the dental hospital anyway?
They're either from the general dental practitioner or from the dental hospital, yeah. Basically, you'll get variations. You'll get some that just partial coverage at the front and partial coverage at the back. You get loads of different ideas. Basically, what we would prefer at the dental hospital is full coverage, and ideally, if you went to Europe, because it's insurers like somewhere like Holland, you get the proper the Rolls Royce, which is a full coverage, even occlusion, and it'll be a hard splint, and that's the idea. The dental hospital do soft splints, and some people just chew on them. So. But they're cheap, and you don't have to monitor them too much. Okay, so medication, psychological interventions, CBT is most common, I think, and it's just to affect habits. Occlusal adjustment, very rare. Botox, rare in Sheffield, other places, Liverpool use that a bit more. Arthrocentesis, which is just a joint washout with a steroid, one needle in, one needle out, steroid goes through, and that's for persistent inflammatory, and also to help with disc movement. Surgery, so like joint replacements, the most, really rare. So really, if you look at guidelines, you're looking at the top three as being the main things, really. The aims of treatment, the general aims of treatment really is to reduce pain, that's what the patients usually come in for, recover function, improve psychological status, which will hopefully help with the other things, self-management, we want the patient to go off and be able to manage it. And it's like in terms of the patient, it's very satisfying because most patients do really well, and we hardly ever see patients come back. Once you talk some strategies, they're fine with that, it's not something serious. And be safe, so make sure you're treating the right thing. Okay, so it's important to remember that we were talking a little bit about that. Your assessment is an important part of your treatment. While you're assessing the patient, the patient's going to be assessing you, and this is kind of butlers, but loads of people think, and I definitely believe this, the patient's assessment of you is going to be far more important to their outcome than your assessment of them. Can you think of any reasons why that might be?
Trust.
Yeah, trust, yeah.
Just getting them on board.
Getting on board, compliance, big one. If they think you know what you're talking about, you're the expert in this, and you've explained things really well, they think, wow, I need to do that he's telling me because he knows what he's talking about, or she. Anything else? Trust, nearly trust, reassurance. If they think you know what you're talking about and you've told them they've got a benign condition that they don't need to worry about it, medically it's not worrisome. Quality of life, big issue with a lot of patients, but in terms of medically, we're not worried about it at all, then that'll make, so some patients that'll make all the difference. Okay. So the interventions that we use, Y-physio, there's some supporting evidence. We are supposedly musculoskeletal specialists, and it's a musculoskeletal condition. We use both biophysical and psychological interventions, which it needs. It's non-invasive, apart from maybe acupuncture. And it's biomedically, it's reversible, not like surgery. Once you put a joint replacement in, that's you. And then finally, it's relatively good value for money. Evidence. Well, these are pretty old, and you'll get more evidence if you do read around the subject, but there's some systematic reviews out there. The main things that we use at Sheffield are, we listen to the patient, acknowledge the problem, and you do this with any kind of a physio problem really. Validate the problem or reinforce that they've got a TMD diagnosis. Reassure and explain about both the assessment findings and the condition. Challenge, or get the patient to challenge their own unhelpful beliefs, if they've got anything. Advise on joint and muscle, stress reduction, habit reversal, postural correction, and we're going to go through all these, jaw relaxation, exercise, manual therapy, and acupuncture. So those are the main things. But what we're trying to do is teach them self-management, so they've got some kind of feeling of a control over their problem, which is going to help them cope. So self-efficacy is the big thing. So we've said already that persistent TMD will be associated with lots of driving factors. We've looked at some of the driving factors, and that we need an assessment to look at what driving factors are there, and so we know what to treat. So what we need both psychological and physical interventions. So starting with the psychological, we mentioned that I mentioned earlier that persistent orofacial pain related to TMD, psychological factors are going to be more important than your medical findings in terms of whether the patient gets better. In terms of their disability and pain, and therefore we're going to need psychological input really. And your biggest weapon here is explanation. So that's, don't underestimate a good explanation to a patient. It's crucial in addressing the psychological driving factors. It helps reassure and reduce the threat. Threats really are really important with persistent problems. Patients, I reckon that probably half of the patients that I know that have had persistent pain with mixed diagnoses for 3 years or more think they've got something like a tumour. Probably easily. There must be, when you ask about what they think, what's the worst thing you think this could be, they'll tell you that you've got some kind of serious problem going on. And if they continue to think that while you're treating them, how far do you think you're going to get? You're not there. So you give them that to do, that's going to, it's not going to affect my tumour, that is it, So this is really, really important for any musculoskeletal problem. You're selling something. It'll also improve the compliance, as we said. It'll give them a rationale for doing what they're going to do. So based on the psychological intervention, from the assessment findings, we're going to reinforce benign diagnosis. So how are we going to do this? Well, you've got that information sheet. So that's slightly different, the information advice sheet you've got from the electronic copy that you've got, because it's been just modified. Now the information sheet is not something I just give a patient and send them away with. What I tend to do is, what I do with all patients, it's I go through the information sheet with them and use it as some kind of structure. So we want to give a definition, we want to tell the patients that this is a common problem, we want to tell them that you've seen all these symptoms before, they're not something you're concerned about, these are not medically worried about them, however their quality of life is being affected because this 1 in 20 that are seeking treatment. You can direct them to a nice, sensible dental website, a medical and dental website with some, and it's worth reading the information on this website actually yourselves. We can use the score for explanations, particularly I use this for joint explanation. I take the patient over to the computer and I show them images. I think they're very useful. I'll show them. So with Mary, I'm going to show her the muscle. I've already got Mary to palpate the muscle, and she knows the pain's coming from there. Now I'm going to give her an image of the muscle, so she knows exactly what the structure is. And I'm going to send her home with this picture as well, so she can tell all the friends and relatives about what she's got now, so to reinforce that even more. I'm also going to discuss a little bit about referral because she's getting ear pain, so I want to reassure her about that. So I'll probably explain, you've heard of heart pain going into the arm, there's nothing wrong with that person's arm, but pain does refer from different structures. So patients, some of the patients I see have got lots of missing teeth, and that's usually because they beg the dentist to remove teeth one by one. Remove the first one, pain's still there, they've asked the dentist, please remove the second one, it's got to be that too. And they'll be missing 3 or 4 teeth on one side because of the foot, and then they'll get a diagnosis, it's a muscle problem. And that still happens. Headache, and with Mary, ear pain, really common. Lots of patients come with ear pain, had antibiotics, B2ENT. So I want to explain the kind of normal movements of the jaw. So when you first open your jaw, like we said before, you probably don't feel any forward movements of the condyle because it's mainly rotating under the disc. Okay. Then when you open up a bit wider, so it's hinging there. And then if you open it wider, then what you get is a forward move. So it's a complicated joint the way it moves. And also when you move your jaw from side to side, you're getting that forward movement of both the disc and the condyle come forwards together. So I'll show you where the disc position is. Separates the joint. It's a bit of cartilage that helps to cushion the joint a bit. I'll show you how it moves in the normal way it should move. It moves between the condyle and the eminence, and then comes back. And then I'll show her on her jaw what her jaw's doing, which is really common in the general population. I don't know if has anyone got a click? Yes. Look. Oh, loads of people have got clicks. So this is what's happening to your jaw when it's clicking. More 99%. What's happening is your disc is slightly forwards. It often happens in teenage years, and it's just that the capsule is slightly overstretched and the disc comes forward slightly. It's a complicated joint, so it happens. And as you open your jaw now, what will eventually happen is that it'll get so far, the condyle will get so far down the eminence, and the disc will just slip back into place or click back into place, go down, and then as you come back, it'll either slip off, or some people get a closing click as well. So really common. Now, so for some people, this can be quite mechanical, and it can irritate the joints and cause inflammation and cause pain. Most people don't get pain, and a lot of people don't even get a click. Why do you think some people don't get a click and some people do? What do you think? And this is only theory. What theoretically could cause some people to get stronger clicks sometimes in their lifetime than others?
Size of the disc.
Size of the disc could be, yes, you could get inflammation and a thickening of the disc. What else? Something that you could change fairly quickly. We talked about it already.
Myogenic component.
Yeah.
muscle
Compression. If you're compressing the joint, clicking. If you're not, it doesn't. So some people, you can demonstrate within one treatment session, you can reinforce your benign diagnosis because they're worried about a click, and the click reduces. Very powerful, like in terms of reinforcing a benign problem. Okay. This is Mary's MRI. So if you can see it, you might have to come a bit closer. So that's her right joint. The disc is located forwards, and when she opens the jaw, it clicks back into position, and that's mainly on the will be on the translation. And as she closes the jaw, it's gone back out. So that's the report, which just tells us what we've just said. So what we've done is given her a lot of information, and the main reason I'm giving her that information is just for her to go away and know what she's got wrong with it, and know what she's not got wrong with it. That's probably more important thing. So we're going to explain how the cycle of pain can be maintained. So I'm going to give a very simple model of pain for the masticatory system. So usually you've got this homeostatic balance where, and this is supposed to be the adaptation of the capacity of the masticatory system, where on one side the system has the capacity to cope, so you've got the coping capacity on this seesaw, and then on the other side you've got driving factors that could actually take the seesaw out of kilt. So you're going to get, in parts of your life, you're going to get some you're going to get some stresses and strains, but mainly the system will cope with that because that's what it's designed to do. But you might get some overload, and that might be micro trauma or macro trauma. And then you get excessive stress and strain, that you can get a perceived threat, which could actually be related to actual or potential damage. What's going to turn on there? The pain alarm system. Okay, so there's a threshold that it'll tolerate, and then you've got this alarm system comes on. But most patients, within a few days or a few weeks, what you'll get is you'll get a reduction in the actual loaders, and you get healing, and then you get a homeostatic return. So a very basic model, and people go past me and I'm doing this in a queue. Right. Right, okay. So, but with Mary, what she's got overload nervous system that is persisting. And the reason why her system is persisting is because of her main driving factors. She's got these driving factors that are just taking the system out of balance, and it just, those driving factors are going on and causing this ongoing cycle. So that's what we've got to really look at. So I'm going to explain the driving factors in a little bit more detail and try to make this more relevant to the patient themselves. So I'm going to go back to the information advice sheet in a moment, but about avoiding habits. Now the main thing about this is on the form. What's the normal rest position here? Yeah, the right one, isn't it? The opening. So your jaw should be slightly open at rest. And if you've got a closed mouth, the muscles are always working to some extent, because if they weren't, your jaw would just drop. They're a sling. But if you've got the jaw with some resistance, you're getting closure, you're hitting your top teeth, you're using your muscles. And people will do this hours and hours. So one piece of literature I read fairly recently was, which is quite nice to tell patients, is that over a time, if you added up all the contact in 24 hours, it suggested that it should be less than 10 minutes. Okay. Now the patients I see, they just sit there. It's just like holding a weight. Your biceps is going to absolutely kill it eventually. Even if it's a very light, or just holding your arm. So normal rest position, we don't want excessive tooth contact. Because again, it's going to increase muscle activity, muscle loading, muscle pain, and joint loading, joint pain, as you said, with myofascial element to the joint problem. So avoid excessive tooth contact. Avoid oral habits. So this is back to the information sheet. So this is what's up. So it's a bit of information about what to look out for. Those are the type of parafunction that we're looking at. Tooth contact is the biggest by far. That's the most thing that I'll get patients to go away just for 2 weeks and just think about how much they're contacting their teeth. And it's also important for patients to know that it's when they're concentrating or when they're stressed that they're more likely to get triggers, because we express ourselves through our face. So if we're telling them not to do something, if I'm telling a patient not to do something, I always want to give them a reference point and tell them what I want them to do instead. So regularly check your relaxed position, so they know what a relaxed position is. And the simple exercise you might have come across with this is, if you say the word Emma, your teeth will be about a millimetre apart at the end of the word Emma. So you get people say Emma, and then as soon as you've got a millimetre, then it'll just suddenly close together after that. The patient. Tongue on the roof of the mouth. Now, speech therapists tell me that if your tongue's just lightly onto the roof of the mouth, it stabilises the mandible to some extent, and then the other muscles can relax a little bit better. So it's not a forced position, it's just what we call the cluck position, where if you cluck, and then just very gently rest your tongue on the hard palate, just behind the front teeth, that's ideal. And we want them to remember to keep your tongue and teeth apart through the day. And this will be the main thing that I want patients to do after the first session. The next thing is forward head posture with Mary. When I'm standing upright, my spine's in a neutral position, and I've got a nice curve in my lumbar spine. If I sit down, I get a pelvic tilt down so my head comes forward. And we spend long periods these days with forward head postures doing various functions. And it's not just the forward head posture, it's the movement within the forward head posture that you're looking at extra strains and stresses. So it's not just, we're talking about static loading, we're talking about both static and dynamic loading in a poor posture. Your head is forward, the weight of gravity is pulling your head down, it wants to fall off the edge of the cliff. The only thing that's keeping it upright is your neck muscles. We're having to work a lot longer for long periods of time. We know from EMG studies, if your neck muscles work harder, then your jaw muscles work. They're a team, and the jaw muscles. So masseter on EMG studies with a forward head posture is working strongly, and you're going to get extra joint compression as well. So, as we said, muscle loading, muscle pain, joint loading, joint pain. So we want to avoid forward head posture as much as possible. And again, it's about selling this to a patient. They need to know why you're asking them to do this. So we give them a reference point, we give them some advice about how to sit at a supported way, not having to use the muscles too much in a supported way. And then we've got other things that we might want to ask the patient to do. So over the next couple of months whilst I'm treating you, what I want you to do is go on a soft diet, because we're trying to bring down that loading effect on the, and try to bring it down for a sustained period so everything can settle down. So eating a soft diet, eating properly, avoiding caffeine, which is a stimulant. If they go to the dentist, one thing you can recommend is a dental prop. So dentists, people would typically dread the dentist, but if you stick a dental prop in there, they can just rest their teeth and they don't have to overuse the muscles to keep it open, stress things. Stick your tongue to the roof of your mouth when you yawn, so if you get into the habit of that, you can't open your mouth too wide with a tongue on the roof of your mouth. Your tongue's far stronger than your opening muscle, it's a muscle itself. Don't rest your chin on your hands, don't sleep on your front, these are going to stress the joints. And then looking at using the bite appliances if they're being given on any medication, and encourage general activity really, cardiovascular walking and things like that, because it's going to help with the relaxation, as long as they're not doing it too late at night. So we're going to discuss Mary's driving factors, particularly, and at the back of your page there's this kind of diagram of a persistent cycle of pain. And we'd ask Mary to think about what we've discussed about the information sheet, and to actually think about, are there any driving factors that she's aware of, and she'll go home and think about any of these driving factors, and she'll come back hopefully thinking about all these things with a list of driving factors. So this was kind of Mary's list that I helped with. So she gave me a long list of things that and some of the things she might not be able to affect, but she's more aware of it. So she knows why, when she's stressed, she's getting a bit more pain. So awareness is quite reassuring with this. So talk about her problems, the goals, how she can actually, what she can do to break this cycle, and then come together with a management plan. So what we're trying to do is minimise these driving factors with the psychological side of things and get this balance again in a masticatory system. So we've done the psychological, now we want to do the physical side of things. So physical intervention will mainly be relaxation, exercise and manual therapy. And the aim of the physical is to treat the physical disorder. So, and the emphasis here should be on self-management to promote that control and self-efficacy. And so we're looking at the other side of the seesaw a little bit. We're probably doing both, but what we're trying to do is increase the capacity of the tissues really here as well. So masticating muscle disorder. So we're going to just things that are slightly more directed to the muscle, the techniques directed to the muscle here. So jaw relaxation technique. So I'm going to get her every evening. She's going to think about her rest position that we've already explained to her. She's going to put her jaw in that rest position. She's going to do some diaphragmatic breathing for 5 minutes and get an actual reference point of what is relaxed. Most of these patients have no idea where they're moving the jaw, what's relaxed, what's not, and it's just going to give us some feedback. So she's got some more awareness of it. So she's got some comparison the next day. So the next day when she's on the computer, she thinks about the jaw, and she thinks, oh, that's not what it felt like last night. So I want them to do this on a daily basis, but just at night when it's convenient to them. They can do it more if they want to. So we're going to use massage and specific finger pressure techniques to facilitate muscle relaxation and muscle flexibility to reduce pain, and followed by some muscle stretching. When we're going to use exercises so she can maintain any gains that we do ourselves. And when you're giving exercises out, I think one of the most important things is letting the patient have feedback. These patients are proprioceptively nothing, so they have no idea what's happening around the jaw. So visual feedback is really important. So either a mirror, with some of the younger patients that come in with phones, I'll obviously ask their permission, but video them with their own phone and go through the technique, and I'll give key points as they're going through. And these aren't my ideas, I've stolen from other people. I wish they were. None of this is mine, I just steal loads of stuff. So how can I promote muscle relaxation and reduce facial pain? Gentle massage, these are simple techniques but very effective, really effective. So gentle and kneading massage, and all you're doing is a circular movement. You're using the skin and muscle interface, so you don't need any creams. The skin and muscle interface are really nice and smooth, and you're just moving the skin on the muscle. You know, so, and we're going to start with the muscle belly. That's where all the firings are probably going on. So use some visual feedback at home once a day. So you're going to do this 5 minutes. 5 minutes is a long time. Massage has been around for thousands of years, and there's one good reason why is because it works. But you have to do it for sustained periods, and the patient needs to know that. So some patients will come in and say, oh yeah, I'm already massaging, but they'll probably do it for 20 seconds or whatever. So if you're in Holland, they'll be saying do it 15 minutes 3 times a day. Imagine any of your patients. I can't imagine my patients doing that. But in Holland, it's so we're going to do this maybe after each meal as a reminder. We could also use kind of trigger point techniques. So trigger points, as I said, not much known about them. Supposedly hyper-irritable taut bands in the muscle, which you can reproduce the pain, both local and referred pain on palpation. And if you inactivate the trigger points, they're supposed to relieve pain. So that's the kind of, there's one theory about them. So, and the cause of trigger points, as I said, not well, maybe neurochemical changes in the muscle where you've got have increased sensitivity due to in both the central and peripheral nervous system. And some of the studies have shown elevated pain mediators around the muscle, around trigger points. So, but we're going to, what I do know is clinically, when you do something to these painful spots, usually you get the opening widens, they feel far more relaxed. So you know, the theory and the seem to relate, whether it's like the theory is right or not, that's another matter. So we're going to use the kneading massage first, but we're going to shorten it to 20 seconds. Then we're going to do kind of a hold. And we might start in the position where we just looked at before, in that corner, and then grip onto the muscle for 20 seconds. In terms of how much pain you want the patient to experience, it's probably not more than 4 out of 10. So less than moderate. So there should be increase by too much. We're not trying to add to the pain cycle. So, and then they're going to give the muscle a bit of a dig from the inside, trying to stretch it. And they're going to do this. Following that, they're going to do an exercise, which I'll show you in a minute. And all this is trying to do is reduce the co-contraction. So we're going to do a Tai Chi type exercise, very slow, deliberate movements after that to kind of calm the system down. So we advise them to do this 3 times a day. You might use acupuncture. I didn't use acupuncture with Mary, but it can be very useful for some patients. But I'd always be reinforcing that the massage on top of that and that their own techniques is what's going to change. The acupuncture is just going to facilitate that a bit. So looking at the joint, so this is the only exercise I'm going to cover with the joint, and it's, you might have seen this exercise before, and it's just opening your jaw in a retruded position, so your condyles are going to stay in the fossa when you do it. So you shouldn't get any clicking. If someone's got a click, when they do that, no one's getting any clicking. And how we're going to try to prevent that is we're going to use the tongue in the club position. That's going to do 2 things. You won't be able to open your mouth too wide, so the condyles won't get into that second phase where they're coming forwards. But also the tongue, like we said, a muscle, and it's attached to the hyoid bone into the mandible. And if you put it on the mouth, what it does, it contracts it slightly and it pulls the jaw, protrudes the jaw, so it helps to keep it in place in the condyles in the fossa. One index finger is going to feel the joint to make sure it's not clipping. The other index finger and thumb are going to just, more for feedback than anything, are going to just put very light pressure on the jaw in a backward position, and as you open, the jaw should stay in the fossa. Just keep your tongue up. And those people that got a clip, if it is clicking, I've not taught you properly. So we'll have a look at this in the practical anyway. So nice, slow, rhythmical movement, Tai Chi-like movement. These patients have got lots of co-contraction around there. Both, and you'll see the jerky movements when they're trying to, the closers are working against the opening muscles. So it's just trying to give that relaxation and also, So with Mary, we've gone through what we said for our general interventions. We've listened, we've validated, we've reassured, we've challenged her kind of mixed diagnosis. We said that we know exactly what it is. We've advised on muscle stress reduction, habit reversal, postural correction, and we've given her some jaw relaxation. That's session 1. So I don't know if do people get an hour? I get an hour, okay, and I need an hour for patients and with persistent TMD, and that's what I'm doing first hour. I wouldn't give them any other exercise or anything like that. What I wanted to go away is think about what she's doing with the jaw. Session 2, we're going to look at the soft. I'll do myself soft tissue technique, and I'll just do massage for a while and see how it felt afterwards. Then I'd get her to massage it, and then I'd give her an information sheet to tell her how to massage it. And I'd also give her the opening protrusion exercise that we just looked at. But I'd tell her to start that about 3 or 4 days after she starts the massage, so she knows if anything's aggravating, what it might be. Then the next time she comes back, then I'd look at the soft tissue cycle. So I'd reduce the amount of massage and the amount of opening and add on. So it still will take about 5 minutes each time she does the exercises. And the 4th session, I'd just repeat massage, recheck her, check all the exercises, and then she was fine. By the second session, she was a lot better, which surprised me really. And I think most of her driving factor was her worry about her concern about the actual problem. So I didn't do this to Mary, but for stubborn clicks that are a bit more painful, you can use manual therapy. And the manual therapy that I tend to use, well, let's just say what manual therapy does, or theoretically, with disc displacement. If you look at where the disc is, it's forwards. So one of the theories about this is that without the disc actually being in its usual location, you get a more persistent rest position of superior and retracted in terms of the condyle. So you might get some. So you might get some that the vertical space is a bit less there because everything's contracted a little bit. So what we're trying to do is stretch that capsule and restore that vertical flexibility. And also, if you talk to surgeons that have done arthroscopies, what they tend to find is that the disc is actually adhered to the eminence as well. So we can help with this as well, possibly. So I'm going to show you a distraction technique today, which I use most commonly with patients, and I'll use that for 2 reasons. Disc displacement, so I'll use it, and also for adhesions. Someone's got had maybe surgery or had a blow, an injury or something, and they've got limited range through that. So, and with all mobilisation techniques, you're going to start. What's going to happen is if you go to a painful patient and you start trying to do strong techniques on the jaw, what's going to happen? You're never going to beat the masseter. It's far more powerful than your hand is. It's a very strong muscle, so you're going to get nowhere. So oscillation, trying to keep everything relaxed. You might have done some of these soft tissue techniques first, and get the patient used to, and then you can start doing more sustained techniques. That's Kevin Banks doing a distraction there. So, finally, why is it important to comply fully? So, I'm also going to give Mary some information about compliance. So, I know that with most patients, they do really well. Even when patients have had years and years of pain, they do well with the treatment. And we expect patients to do well. And it's the only way, if they comply, that we know whether these techniques are going to work or not. So if she complies and it works, she's always going to have something in her drawer that she can go back to if it flares up again. If she's complying and it doesn't help, then I'm thinking I've probably missed something. Either we've missed another contributing factor, another driving factor, and that needs a different type of treatment, or that we've not got the correct diagnosis. Okay, so treatment practical. What is it? 11.
It's okay, you're going to have our check on timetable and we'll leave 2 menopause.
What are we on? Oh, right. Okay.
Going to happen.
Oh, right. So, practical. So we're ready for practical. So this is what we're going to cover. So the first part of the practical, all I want to do is get you to try some techniques on yourself. You can use a one if you want, or if you dare to use your dirty hands, you can use your dirty hands. You see when you have patients in front of you, you say, right, I want you to put your hand in, and you can see the patients I don't like. So you can either wash them or use gloves, whatever. Okay, so you're all happy to use your hands, obviously. Well, right, okay, so the first technique is the massage technique. So all that you're going to do for the massage technique, you're looking at the manual and you think about where the angle is. If you move your fingers just up and forwards and put them, that's done at 6, I think it's 6 or 7, and then clench, you should feel that your fingers come out like, yeah, if you clench, you feel the muscles are contracting. So now you're going to put your fingers, and you're going to use lots of contact with the muscle. You're going to put your fingers over that kind of area, and that's going to be the area that you're going to be working on. You're going to keep your fingers in contact with the actual skin, and move the skin on the muscle, nice and gently, in a circular way. Nowhere else but physio would you get this, would you? So, and it doesn't matter which direction, and the patient's just going to continue doing this. And it's amazing how effective, just after 5 minutes, that this effect. What I meant to ask you to do, which you could do before starting the actual techniques, is to measure range of movement. Because I do these courses around the country, and we always get them to measure range of movement first and afterwards, and it will affect the range of movement with most people. So you do for 5 minutes, so we know that technique. The second technique I want to try is the opening with retrusion. So you want tongue on the roof of your mouth, or cluck. Good, and then keep your tongue on the roof of your mouth, just behind the front teeth on the hard palate. So the tip of the tongue stays on there. I want you to have a feel if you have got a click. If you haven't got a click, it doesn't really matter. And then what I want you to do is a very gentle feedback type pressure that's going to just push back towards your throat type thing. So when your jaw comes down, it'll go down and backwards. So it's just any clicks. Yeah, so you wouldn't expect it. The click is going to happen when the condyle comes forwards. The condyle's not going to come forwards with this, because we've got loads of things, loads of support. Now, how we progress this exercise is we take away some of the support. So we're trying to improve a pattern of movement. A lot of the patients you see will protrude too much in their function, so they'll do a lot of protrusive activity far too early, and that might be one of their sources of pain. So we're teaching a different way of moving. Okay, so. And it also helps with the muscle in terms of co-contraction. So that's firstly. Now we're going to try the soft tissue technique on ourselves. Okay, so you do a bit of massage. I think we all know how to do that now. So we're going to go in with the thumb, and you're going to take your thumb along your cheek until it hits this bone here. Then I want you to slide your thumb up the bone, and you should be hitting this bone here, the zygomatic arch, and then you should be in a corner. So you're using the opposite hand to the side, okay? So you're going across your body, because your thumb's got to go in this side. And you do get patients coming back doing this type of thing, more comfortable. So you go into the opposite side. Once you're in that corner, then I want you to take your fingers to your earlobe, and then I want you to gather the muscle and pull it towards your thumb. And most people, they'll be a little bit tender. Yeah. So you give it a bit of a squeeze, but don't squeeze it too hard. So that's what you do then is hold it for 20 seconds, and then what you're going to do then is through that corner, you're going to push your thumb into the corner, into the muscle, kind of over your shoulder. But if you push directly backwards, you just go to the bone. If you push directly upwards, you go to the bone. So you're going slightly out and through. And it's probably, in those patients, it'll be quite a tight movement, and you're just pushing into the muscle, really. So, okay, so that's the technique. So what we're going to do now is I'm going to do some of the, we'll do that we'll do the actual soft tissue techniques on somebody. Okay, so, did anyone have a reduced range of movement? Did anyone actually measure? Did you? Oh. So let's see what's the first one. Have you got any problems with your jaw?
Any
Trouble with pain?
just clicking
it. So really, with these techniques, really be careful, particularly the manipulative technique. Be really careful with that. So because we don't want to go home with be nice and gentle on people. Okay, so we've got to get some. So it might be an idea just to measure everybody's jaw again before you do it, and then we'll run out. So rotation, you're fine. That's about 43 millimetres.
Might be all that massage.
Hey?
It could be all the massage.
Okay. Yeah, it might be. Thanks for that. Okay. Okay, so we're going to do this technique. So I'm going to just run through the whole technique, really. You can just all have a quick go. So the massage. So I've got his jaw angled here. He's got a nice, really nice, thick masseter on both sides. And we're just going to just keep hold of his skin and just. And if he gets any problems, he can lift his hand up, or he'll just say. And that's the technique. So with someone that's quite sensitive, you might be just doing very slow, nice, gentle techniques. But people that with restriction, without too much pain, you might want to do deeper techniques. Depends on the sensitisation. That sin factor that I don't know if we still talk about. Okay, so that's the technique. And what I'm going to do is I'm going to get him to open. And I usually do both sides of the muscle and then close and just open a little tiny bit. And then I'm just going to go to the back, on that bone, up to the top, and go to the ear, and I'm just going to collect it. Now, you don't have to do this point. There's lots of muscle there I could do it on, but it is quite a common point. And then I'm just going to squeeze, and if it gets too much discomfort, 4 out of 10 maximum. Squeeze, hold, 20 seconds. And then what I'm doing is just slipping off the bones and just going through that corner. I'm in the corner there. Holding for 10 seconds. And that's my technique. Then I'd get him, I might do the other side, but then I'd get him to do the retrusive exercise after that. And then I'd do 3 cycles, but 2 of the cycles I'd do, then I'd get him up and he'd do the last cycle, and that would be what he'd go home with. Do you want to have a go? So I'm just going to show you one manual technique, which is kind of the start of most of the techniques I use anyway. So I want the patient to come towards me because I want to be really nice and comfortable. I'm going to just have a feel of the joint on this side with my middle finger and index finger. Ask him to open. Now I want him just to close nice and gently onto my thumb. Okay. I've done some soft tissue techniques, so I know that it should start loosening. So I'm going to just grip the mandible nice firmly, and then I'm just going to distract by just pulling it down. So I might start with just some oscillations. And I'm fighting a masseter muscle here, and it's quite tight, and it's not really letting me do much at the moment. So if that...
Is your thumb with you? Between his teeth?
I'll show you on the skeleton in a
Yeah.
moment. Yeah. So I'm just gripping the molars at the back and the mandible, nice and firm. The firmer you are, not obviously not too tight, but the more comfortable the patient will feel. And just if you just open for me, and then close, and then open, close, and open.
So you're just doing a longitudinal cord dad?
Yeah.
Yeah.
Yeah, just going straight down to his chest. Okay, and that's one way of loosening it off, so it's a little bit looser. If you get him to actually use the opening muscles to open and just put a little bit of pressure on there, you could get him, but he'd just be nice and gentle. The other way you could do it, if you dare, is get him to actually bite your thumb a little bit. But I don't recommend that, too much all over. And then he'll know the difference between relaxed and not. So, and then just open, and then close, and then just let your joint go as best you can. So yeah, so he's finding quite, you can get a little bit of movement, but I reckon that joint would move a lot more if it was more relaxed. So I'd have to spend with you quite a little bit of time doing some very gentle stuff, doing massage, and then alternating it. Yeah? Okay, so have a go, and then I'll come round. I'll show you on the skeleton. So my hand, I'm feeling the joint from here with my middle finger. Thumbs in here. These techniques you can see in the DVDs and things in the literature. And my thumb is far back as comfortable on here, and all I'm doing is I'm stretching the jaw. So imagine that the disc, right? Imagine that this is tight, and this has got to go over the disc and relocate on a disc. And the back of the disc is obviously, it's bow tie shaped, isn't it? So the back of the disc is thicker. It's got to go over the top. And if this is tight, it's going to be having a bit of problem getting over there, isn't it? Particularly if the muscle's tight as well. So all you're trying to do is give a little bit more vertical flexibility, theoretically. Okay, so it'll go over a little bit easier. Okay, and most of my techniques will just stem from this same work. And you can look in the Maitland books and the videos, and also in the Olsen video also shows that technique. Simple techniques, they're dead simple. Once, just before, yeah.
You could go on, you could go on.
Yes, okay, just go and have a